Members, the first bill on the agenda for today is House File 348. I will move that House File 348 be recommended to be re-referred to the Health, Finance, and Policy Committee. And Representative Howard, welcome back to the committee. Looks like you have a DE1 amendment.
Yes, Madam Chair,
Right.
I would present the bill in the shape I would like it in.
I will move the DE1-1 amendment. Representative Howard, would you like to describe that amendment, or does it simply get the bill in the shape that you would like?
It's just to get the bill in the shape that we
Very good.
would like it in.
Members, any discussion to the adoption of the DE1-1? All those in favor, please say aye. Aye. Any opposed? The motion prevails and the amendment is adopted. Representative Howard, to your bill as amended.
Chair, members, it's nice to be back in Commerce on the side of the table. On a bipartisan basis, over the past many years, this legislature has passed a series of new laws to help reduce the cost of prescription drugs. And this bill is a logical next step in our shared work to ensure that Minnesotans can afford the prescription drugs they need to survive and thrive. As many of you know, and as many of you worked and helped with, we passed a nation-leading bill, the Alex Smith Insulin Affordability Act, that is designed to prevent Minnesotans from losing their life because they can't afford their insulin. A version of this bill was part of Alex's bill that didn't get across the finish line, and it's long past time to take action. House File 348 would place a copay cap of $25 a month to help Minnesotans cover 3 chronic conditions: diabetes, asthma, and allergy conditions, all of which impact thousands of Minnesotans, all of which come with potential grave consequences if not treated properly, and all where medications and supplies to manage these conditions have skyrocketed. The high cost of insulin has been widely discussed by this legislature and continues to be a huge burden on Minnesotans. Asthma is a condition that impacts thousands of Minnesotans, and a recent study showed that the average asthma patient pays almost $2,000 per year in prescriptions. The bill also focuses on EpiPens, where we have seen skyrocketing prices as well. Importantly, this bill would also place a $50 monthly copay cap on medical supplies to manage these conditions. As you'll hear from testimony, there's families that are actually paying more for the medical supplies to manage their conditions than the prescription drugs, and these are having perverse outcomes. Patients are sometimes forced to choose inferior methods to manage their conditions simply based on cost. On this point, the ADA found that 15% of people with diabetes who rely on pumps or CGMs have delayed refilling needed supplies during the pandemic, and for 70% of them it was due to finances. And look, this should never happen. The cost and the terms of an insurance company should not dictate treatment. That should be between a doctor and a patient. And this bill will help provide peace of mind to families about the cost of those supplies and will lead to better health outcomes as well. It is worth noting that when Minnesota passed Alex Law, we were the first in the nation to do so, since many other states have done so or are seeking to do so. But this bill, copay cap, is an area where we're actually falling behind. It's an issue that has not been controversial. Over 20 states, red states and blue, from Washington, Oregon, Utah, Oklahoma, Texas, and the list goes on, has a similar legislation in place, and it's time we do as well. A couple final points before we hear from testifiers. Because we are lagging other states, we now have data from other states that support its value and discredit the claims we've heard about potential impacts. Following Colorado's legislation, they were the first state to move in this direction. A study reviewed documents from 21 health plans and found placing a copay cap on insulin either did not impact premiums or it was described as negligible. Members, for years, the insurance lobby has opposed this bill under the guise it will lead to significantly higher premiums and copays. They've never offered a shred of evidence to back that up, but now we actually have some good data. Due to bipartisan legislation authored by Senator Benson and Representative Elkins, any cost-sharing changes must undergo a thorough actuarial analysis by the Department of Commerce, and this proposal went through that assessment. In total, the report found negligible long-term cost increases to overall premiums and copays if this bill becomes law. It found that the monthly cost for copays would go up 2 pennies per year. if this bill, and the monthly cost of premiums would go up $1 per year if this bill was put in place. And additionally, the report showed many downstream savings because we will see better disease management if Minnesotans can afford their prescription drugs. An NIH study found the rate of hospitalization decreased when anti-diabetic drug adherence increased. And the same can be said with asthma medication, where an NIH study demonstrated that increased inhaler adherence could save hundreds of dollars in healthcare expenditures per child. And again, these statistics are about the savings to our health care system. That should only be a secondary reason we pass this bill. The most important is we know that Minnesotans are struggling and that this change would drastically improve both their bottom lines and their health. And it's really the ultimate no-brainer, and I look forward to hearing the discussion and testifiers that will do a better job myself of helping make the case for why we should move in this direction.
Thank you, Representative Howard. So we have 3 testifiers signed up. First is Carissa Kemp with the American Diabetes Association, followed by Adrian Thornton with Children's Minnesota, and Emily Hassenstab, also with Children's Minnesota. We have a number of testifiers and a number of bills on the agenda for today, so we are going to ask that folks keep their testimony to about 2 minutes if you can. Thank you so much. Introduce yourself and proceed with your testimony.
My name is Carissa Kemp. I'm the Director of State Government Affairs with the American Diabetes Association. Chair Stevenson and committee members, my name is Carissa, as I just said, my name is Carissa Kemp. Thank you for this opportunity. The American Diabetes Association published a Health Equity Bill of Rights, which envisions a future without unjust health disparities. The legislation before you takes steps to address 2 critical aspects of the ADA's Health Equity Bill of Rights. The first is the right to access insulin and other drugs affordably. People with diabetes account for 1 of every $4 spent in healthcare in our country, and growing numbers cannot afford the medications they need to survive. People with diabetes should not be able to, or should be able to get medication without having to choose between filling their prescriptions and other essentials. The second, and this bill also addresses this critical aspect, is the right to the latest medical advances. Medical technologies like continuous glucose monitors and insulin pumps, which would be impacted by House File 348, can be instrumental in treating and managing diabetes. Still, many people with diabetes do not have the same access to these life-saving technologies as do higher income peers. The latest advances in diabetes management should be accessible for all who stand to benefit. We also have evidence from other states, which Representative Howard spoke to, and also from the Commerce Department evaluation of the bill that shows this will have a minimal impact on premiums. At the same time, this legislation can improve health outcomes, reduce use of emergency rooms, lower the risk of developing complicated and devastating complications, all while ultimately lowering healthcare costs. Thank you again for the opportunity to speak in support of this important legislation, and I urge your support.
Thank you for your testimony. I'm not sure if our next 2 testifiers are testifying together or separately, but Adrian Thornton and Emily Hassenstab with the Children's are up next. Thank you. And introduce yourself and proceed with your testimony.
Thank you, Madam Chair and Committee. I am Adrian Thornton, and I am the Manager of Health Equity at Children's Minnesota. I'm very grateful to join Representative Howard in trying to get this bill passed. I started my career as a nurse and an infection preventionist, and I've worked at Children's Minnesota for over 20 years. The patients and families that we represent are vibrant and diverse, many of which are systematically disenfranchised. Almost half of our patient population is enrolled in medical assistance and live in socioeconomically depressed areas. Access to health care is not equitable in Minnesota, which leads to grave disparities in health outcomes, impacting our state's Indigenous, Black, Latino, and Asian communities most directly. This is clear when we look at health outcomes for the patients we treat for asthma and diabetes, my daughter being one of them. I have a very close friend whose daughter has type 1 diabetes. I have really vivid memories of sitting on the floor with her and crying because she was afraid that her daughter would not be able to live independently as an adult because of the cost of her medication. When the Alex Smith Insulin Affordability Act was passed, it provided incredible relief. My friend and her daughter were no longer forced to include the high cost of insulin in their monthly budget. My friend's daughter is independent and happily married today with a wonderful husband who helps her manage her diabetes. Unfortunately, due to the type of insurance she has, the copay for her insulin is in the hundreds of dollars. So they've had to opt to purchase their medications from Canada. The almost happy ending to this story is because of Minnesota's ongoing efforts to make insulin more affordable, but we have to go further. The provisions in this bill are needed because far too many families still cannot afford life-saving medications, leaving them with impossible choices. Thank you, Representative Howard, for your leadership on this bill. Thank you, committee.
Thank you for your testimony. Emily Hassenstab is next, and then I have Leah Greenside. Please introduce yourself for the record and proceed with your testimony.
Thank you, Madam Chair and committee members. My name is Emily Hassenstab. I am a nurse and diabetes educator at Children's Minnesota. I've also been living with type 1 diabetes for 18 years. This bill is near and dear to my heart, both professionally and personally, and I thank you for having me here today to express Children's Minnesota's support for House File 348. Children's Minnesota is the largest pediatric healthcare provider in the state. I have the privilege of working with patients and families in our diabetes center, where we serve over 2,400 patients. Our journey with these families often starts with one of their hardest days, the day they learn that their child has type 1 diabetes, a chronic disease with no cure. This is the day a child learns that they need to take medication and will be poked multiple times daily, every day, for the rest of their life. Families' lives are turned upside down by this diagnosis. On top of learning how to manage a chronic disease, they also now face the financial burden of purchasing the medication and supplies required to keep their child alive. I want to tell you about a patient I recently worked with. I'm going to call her Sophie. Sophie was a typically developing 3-year-old child who suddenly started losing weight and regressed in her potty training. Her mom, a single parent, addressed this quickly and brought her in for an evaluation. Sophie was diagnosed with type 1 diabetes, and our team got involved teaching her mom how to check Sophie's blood sugar and administer insulin injections, along with many other skills necessary to keep her alive. We sent prescriptions to their pharmacy, and Sophie's mom called us crying because their copay was over $1,600. None of these medications were optional, and over half of them need to be refilled every month. This is not an uncommon situation that we face, and it needs to change. Today, I ask you to empathize with this family and every family managing chronic disease. Try to imagine first the toll that a chronic disease diagnosis can have on a parent and their child, and then the unbelievable stress of knowing that the financial barriers to accessing the required life-saving medication and supplies, that it's next to impossible to overcome. This bill would not only provide relief to so many of the families that I work with, but it would also save lives by helping people access the required medications they need to survive. Thank you, Representative Howard, for your leadership.
Thank you for your testimony. Finally, Leah Greenside. Introduce yourself and proceed with your testimony.
Thank you, Madam Chair and members of the committee. My name is Leah Greenside. I live in St. Paul with my husband and 2 children. My daughter was diagnosed with type 1 diabetes 10 years ago when she was 7. We're small business owners, and we get our insurance through MNsure, and we've purchased plans through UCare for the last several years. In 2022, my family paid, we just did our taxes, we paid about $18,000 in medical expenses. This included over $13,000 in insurance premiums and $5,000 in out-of-pocket expenses. Diabetes medications and management tools accounted for about $4,000 of our total out-of-pocket medical expenses last year, or roughly 80%. So to break this down, we paid about $500 in total for my daughter's insulin and other diabetes medications, but that's only thanks to UCare's voluntary monthly cap on insulin costs. Otherwise, we would have paid thousands of dollars more, literally. We paid about $3,500 for my daughter's insulin pump and related supplies like infusion sets and continuous glucose monitors. I have an entire cabinet filled with stuff like this that I could show you. If this bill were law, my family would have saved about $3,000 in out-of-pocket medical expenses last year related to managing my daughter's type 1 diabetes. So those people who argue against this bill will claim that cost sharing is needed to put a downward pressure on the rising cost of healthcare. I can tell you the reality, though, as an individual consumer, I essentially have no power to lower my healthcare costs. And I'm going to tell you just a quick story from last year. Last year, I spent over a month trying to get the best price on a new insulin pump. This is the old one that's out of warranty that we can't use. Even with UCare's help, I was only able to find 2 in-network distributors, and it was impossible for me to learn how much the pump would cost before I actually bought it. Most maddening, I couldn't even buy the pump from the lowest cost that I found, which was directly from the manufacturer. The manufacturer's retail price for the pump was just over $5,000, but the retail price that UCare's preferred distributor, Fairview Pharmacy, quoted me was nearly $13,000, $8,000 more than the manufacturer's price. So I had to just buy the pump, not knowing what I was going to pay. 6 months later, in September, I got the bill. The negotiated price of the pump that UCare had was $7,600, which is better than the price that was quoted me, but still nearly $2,500 more than if I had bought it directly from the manufacturer. So in the end, we had met our deductible. We paid our 20% coinsurance, which was $1,500 for the pump. So in short, I found out that my insurance company's preferred in-network vendor was significantly more expensive than if I'd been able to purchase the pump directly from the manufacturer and cut out the middleman. So this cost both me and my insurance company money, which is passed on to all of us in our premiums.
Greenside, I'll just ask you to wrap up.
Yep. I just want to say our system's broken and it's not a free market. Families like mine need your help to relieve the burden and cost of diabetes while we wait for broader healthcare reform. Thank you.
Thank you for sharing your story with us. 3 members of the public signed up to testify. First is Paige Ma, followed by Dan Andreessen and Peter Nelson. You can, Paige Ma, you're up first. Introduce yourself when you reach the table and proceed with your testimony. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Paige, and I am the mother of a child with multiple life-threatening food allergies to common foods such as dairy and peanuts. I am grateful to have this opportunity to give some brief personal remarks today. Our daughter was first diagnosed with allergies when she was only 9 months old, and this diagnosis turned our lives upside down. In addition to managing the purchase of allergy-friendly food substitutes, many of which are much more expensive, we also needed to purchase epinephrine, or EpiPens as they're commonly known, to always have with us, which we immediately did. Yet it wasn't until she was 2.5 that we discovered how severe her allergies actually are. She accidentally ate some food that she is allergic to, and then subsequently and rapidly developed problems with breathing, one of several steps in the reaction known as anaphylaxis, which is the most severe kind of allergic reaction. This required an immediate trip to the emergency room where she was given an EpiPen, followed by a 6-hour observation period to rule out a rebound reaction. Since that time, we now always carry an EpiPen 2-pack with us, have been properly trained, and have additional sets of EpiPens at school and in the nurse's office. Our child has suffered multiple anaphylactic reactions due to the severity of her allergies. The good news is that every time, her life was saved with epinephrine. At this point, Epi is the only treatment that will halt an anaphylactic reaction, and every allergy patient must carry a 2-pack at all times. But despite the good news about the effectiveness of epinephrine in halting an anaphylactic reaction, this leads us to a challenging situation for many allergy families. Most families with school-aged children need at least 2 sets, one to keep in the nurse's office at school and one to keep at home. If children participate in any other after-school activities, daycare, sports, etc., those areas may need independent sets as well. Sometimes there are additional caregivers, such as grandparents or other family members, who should also keep an EpiPen set at their house. This may require additional purchases. So a family may require 3 or 4 sets, but need at least 2. My daughter has had serious allergies for over 9 years. Our first copay years ago was around $60 per set. Last week, I refilled her EpiPen prescription, and our copay
Just
is
ask
now,
you to wrap up your comments. Thank you.
thank you, $125 per set. So in closing, I would urge the committee to help the thousands of allergy families in the state of Minnesota by helping them meet their children's basic needs of epinephrine prescriptions. These sky-high costs are not sustainable long-term for allergy families, and help is greatly needed. Thank you for your leadership and for this time today.
Thank you for sharing your experience. Next, we have Dan Andreessen with the Council of Health Plans, and then Peter Nelson. Introduce yourself and proceed with your testimony.
Madam Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. The council shares concerns raised regarding the cost of prescription drugs to manage these conditions. It's unconscionable what manufacturers of these drugs charge consumers, especially given how little it costs sometimes to manufacture these drugs. We understand the desire to limit what people pay out of pocket. All council members on the fully insured market have already lowered their prices for insulin to less than $25, and some are at zero. However, the decision before you is not without consequences. Unfortunately, passing this bill does not reduce the prices of these medications, and capping copays will mean costs will be shifted to premiums or cost sharing for others. Now, it is fair to say that some of these costs may not show up in premiums. If you're trying to set up a product that is maintaining those premiums, you may want to shift those to cost sharing. And for the individual market, this shift will have to result in increase in cost sharing because of other federal regulations health plans have to follow. Health plans have many regulations that they must follow, and any new regulation has an interaction with that existing regulation. So you remember from my testimony a few weeks ago that products in the individual market must fall into one of 4 tiers, and each one of those tiers has a defined ratio of premium to cost sharing. For example, the bronze level plans all must have a 60% premium, 40% cost sharing ratio. Since this bill caps cost sharing for those drugs, cost sharing will need to go up for other services or medications in order for plans to meet that 40% threshold. Also, this bill will have interactions with other bills that have been moving this session. This committee a few weeks ago passed a bill to eliminate cost sharing for all secondary breast cancer tests. When you combine this bill with that bill before you today, there's going to be a cumulative impact when it comes to cost sharing shifting. And lastly, I just want to we often pass legislation in this at the Capitol and never go back to see what happened. If the committee and the legislature chooses to enact this legislation, one thing to throw out there is to require maybe a study of this mandate to look back to see what were the impacts of the passage, where health outcomes improved, and what were the financial impacts. Thank you.
Thank you, Mr. Andreessen. Peter Nelson? And then I will ask if there's anyone else in the public who wishes to testify on this bill before we proceed.
Hi, Madam Chair, members of the committee. My name is Peter Nelson. I'm a senior policy fellow at Center of the American Experiment, and I'm here to urge you to not micromanage health plan designs. In the health plan, for people with health plans, there is overuse of healthcare through health plans, and there's underuse of healthcare through health plans. I mean, that's a well-recognized issue within the healthcare research. And in this case, I appreciate what you're trying to tackle here and to tackle the issue of underuse. And I absolutely appreciate that, but health plans are challenged with balancing that underuse-overuse issue. And I think they are the best positioned to meet that challenge. And we've seen over the past few years how health plans have treated certain medications for diabetes and other chronic conditions. And the IRS recently actually issued a notice basically allowing high deductible health plans to offer preventive services at no cost for many of these conditions. So we all see this happening, and that's why I really don't think that this bill is necessary at this time, and also in the context of the fact that we're finally starting to see some prices come out through transparency efforts, which will hopefully shine a light on some of the issues that we're seeing here. And finally, I just want to also note one more issue with this bill, and that is the fact that it doesn't appear there's a non-neutral basis for selecting these 3 particular drugs. There's other people with chronic conditions that have issues as well, and as the last testifier basically just stated, by taking this action, you are necessarily increasing costs on other people, and so you have to weigh that yourself. And I think that health plans are in a better position to weigh those issues. So appreciate your time. Thank you.
Thank you, Mr. Nelson. Is there anyone in the public who wishes to testify on the bill? Seeing none, it looks like we do have an A1 amendment. Representative O'Driscoll, would you like to describe and move the A1?
Thank you, Madam Chair. Before I offer the A1 amendment, I do have just a quick question for the bill author.
Representative O'Driscoll, your mic is not working.
All right. Madam Chair?
That's much better. Thank you. Want to make sure your comments are on the record.
Thank you. I appreciate that. As I was saying, before I offer the A1 amendment, I do have a question for the bill author on the DE amendment, just to make sure that I've got some clarity on here. Representative Howard, on lines 1.9 to 1.11 on your DE amendment, the full sentence that begins on line 1.9, it says the cost-sharing limit for related medical supplies does not increase with the number of chronic diseases for which the enrollee is treated. Could you explain to me what the intent or what that means?
Representative Howard.
Madam Chair, Representative Driscoll, as we talked with nonpartisan, we included this line to capture if somebody, for example, has 2 of these chronic conditions. So let's say if you're someone that has diabetes and you have asthma. And so we're trying to, that's what the intent there is with that sentence.
Representative O'Driscoll.
Thank you, Madam Chair. So Representative Howard, if I were to be, my medical condition was such that I might have needed 2 or 3 of the combinations of things that are here, I would still be stopped out at $25 for all 3 or up to 3 and up to 50 on medical supplies per month. Is that what I'm hearing you say?
Representative Howard.
Madam Chair, Representative Driscoll, I might ask nonpartisan to be sure. We do have, it's 25 per month for each prescription drug. And then with the medical supplies, it would be topped out at that 50, I believe. But I might go to nonpartisan to make sure that my reading of that is correct.
We have Randy Chun. Will introduce yourself for the record and respond to the question. Thank
Madam
you.
Chair, Randy Chun with House Research. What Representative Howard is correct. The $25 is per prescription. So if you have 3 prescriptions over, say, 2 chronic conditions, that would be $75. The $50 is a total aggregate, no matter how many chronic conditions. So if you need medical supplies for 2 chronic conditions, you'd still be limited to $50 as the limit.
Thank you for that. Representative O'Driscoll.
Yeah, that helps me to be able to better understand and explain why I'm offering the A1 amendment today. As the bill has been amended with the DE, we basically are saying that if you have any one of these 3 conditions, there are medications that are out there right now in the marketplace. There are certain delivery systems or supplies that are available to help administer those different remedies or medications or prescriptions. And what the A1 amendment does is it says, in the enactment date of January 1st of 2024 with this bill, what we will do is we will say that any of those drugs and medical supplies that are currently available in the marketplace would be subject to the limits that were in the DE amendment. Why is that important, that we wouldn't necessarily go forward with prescriptions that may not have been approved until after that date? Because of the advances in medical technology, advances in medical medications, these other medications or prescriptions may be at a higher price point to the insurance company or to others for out-of-pocket expenses. And what it does is it could inadvertently build in cost escalators inside the insurance plan if we don't put some kind of a collar on here with a particular date going forward. We would have to revisit those particular prescriptions or those particular medications. And it just says we're going to lock in with what we currently have under the current law, and we wouldn't expand that for new medications under the current law because we just don't know what we're dealing with. And so I think it's a good amendment. It provides clarity. It gives folks what they're looking for, but also protects them on the downside where there could be, again, those additional medications or procedures that may cause the cost of insurance to escalate, and more people could find themselves without insurance or right back into the same situation without readdressing the situation at some point should those other medications or technologies occur. Thank you, Madam Chair, and I look forward to a yes vote by all members on this.
Thank you, Representative O'Driscoll. Representative Howard, any comments?
Madam Chair, Representative Driscoll, I understand the intent here. I would respectfully urge a no vote. One thing we're driving after here for Minnesotans is that peace of mind, that managing these incredibly complex, incredibly expensive conditions, that when they go to the pharmacy, they're going to have sort of a peace of mind about how much they're going to be paying for, whether it's the drugs that are currently available or new drugs. So I don't see a reason to exclude that. And I believe it's in the interest of Minnesotans that we establish that consistency. So I would urge a no vote.
Madam Chair?
Representative O'Driscoll.
Thank you. Representative Howard, I know that you have sat on this committee before, and last week we had the opportunity to hear a bill that talked about increasing and expanding Minnesota Care for all Minnesotans. Can you tell me, would Minnesota Care be covered under 62Q.481, which is the subject area of this bill?
Representative Howard.
Madam Chair, Representative Driscoll, the public programs like Minnesota Care would be included.
Representative O'Driscoll.
Well, thank you, Madam Chair. Once again, this just underscores why this amendment is so extremely important, because if we're going to be expanding this coverage, we're going to have a lot more folks who are using it, and it's going to put a plan that we learned last week that really it's the taxpayers who are backstopping Medicare, or excuse me, Minnesota Care right now, and we don't have an actuarial review of actually how much additional costs that would be to the state of Minnesota for expanding Minnesota Care. I think that this is just a very prudent thing to do, and again, it can be readdressed at some point in the future when we have more information and more data, but to go in unguarded like this could be very dangerous to all persons covered under health plans here in the state of Minnesota, including Minnesota Care. Again, I encourage folks to vote yes. Thank you, Madam Chair.
Thank you, Representative O'Driscoll. I have two members on the list. I'm not sure if those are to the amendment or to the bill as a whole. All right, Representative Cagle.
Thank you, Madam Chair. And I just think about my brother and his asthma, and if there was a drug that came out in, April of 2024 that better managed his asthma and put his life at less risk, I would want him to have access to that. So I also urge members to vote no.
Any further discussion to the A1 amendment, members? Seeing none, all those in favor, please say aye.
Aye.
Those opposed? No. The motion does not prevail and the amendment is not adopted. Now, members, any discussion or comments to the bill as a whole? Tina, excuse me. Chair Liebling.
Thank you, Madam Chair. So I just wanted to make one comment because thank you for your leadership on this always, Representative Howard. You've really been very dogged on this whole issue for pretty much as long as I've known you, I think, which is we really appreciate. I just wanted to make a comment about one of the testifiers was talking about how these out-of-pockets prevent over and underuse and about shifting the cost to other people in the insurance. And I have to say, in this context, I find that absolutely ludicrous. And the reason is that, listen to the testifiers. We're not talking about people who have the option not to use their diabetes medication or supplies. They've got to use it. And they're not going to use more of it because it's cheaper to them. They have to have what they have to stay healthy. And the same is true with the other medications. I mean, it's just ludicrous to think that there's any elasticity here. And some of the written letters from the same testifier, actually, is talking about, let's see. There's little evidence that high co-payment costs are posing an obstacle to the appropriate use of the drugs in this bill. Really? I mean, you and I spent a year trying to negotiate the Alex Smith insulin program for that very reason, that people die. They literally die because they can't access these medications. So I just find that absolutely ludicrous. And the other thing I just want to mention briefly, the idea of shifting costs to other people. Well, when somebody gets really sick with diabetes because they don't have the appropriate medication, or their asthma's out of control, or they have anaphylactic shock and they need to be in the hospital for 3 days because they didn't get appropriate treatment immediately, those costs are also shifted. So what are we talking about here, folks? This is a really important bill, and thank you, Representative Howard.
Representative Dowd.
Thank you, Madam Chair, and Representative Howard, thanks for your work on this. I was able to work with you on that working group that we did a few years ago prior to the bill passing. Sometimes I think we talk about, and I appreciate Representative Liebling's mentioning that people can die. And I think sometimes we have a tendency to talk about the extremities of these issues in committee and on the floor. and people at home only hear what we say and they don't always know the background. And I don't think we should ever have this conversation without letting people know that if you can't afford your insulin, that you should call one of the manufacturers. They all have a program. They all actually did prior to us passing that bill that was as good or better than the bill that we passed. And they will make insulin available to you for free or almost nothing in every case. So please, if you're having trouble affording your insulin, reach out to them. And I want to applaud the work that they do. We shouldn't pit manufacturers against insurers or government against manufacturers. They did really great work, and they were actually earlier to this problem than we were. And they had actually already put in place programs to get people insulin for nothing in almost all cases. So I just want to mention that and make sure that people know if you're having trouble affording your insulin, there are programs available. No one should go without.
Representative Cleburne?
Thank you. The reason we're here today is because the current structure that we have is not working for families. I just want to tell the story of Joseph, a 16-year-old boy whose family was struggling. The father was a state worker, but had used up most of the money that they had already to care for Joseph's insulin. And the family had gone out for the day and had left Joseph home alone because he wasn't feeling great, because his activity structure was such that he really needed more insulin than his monthly supply provided for him, because not every child is the same. When they returned home from their outing that day, they discovered Joseph on the floor of the bathroom. Joseph had undergone shock, and Joseph was found with his incomplete organ failure. By the time they got young Joseph to the hospital, his organs were functioning at 40%. Young Joseph spent a week and a half in ICU, and then again 3 more weeks in the hospital thereafter. All of this pain and suffering could have been avoided if the family had access to the ability to get affordable and adequate insulin supply. Now, everybody talks to me about the sound of my voice, the raspiness of my voice, and it's because I use asthma inhalers. I use 3 every day for my own health condition. And when you cannot breathe, there's no, oh, let me go find a coupon. You can't breathe. And a trip to the emergency room is sometimes too long. I mean, we are talking about the very fundamental life-saving medications that keep people functioning. When you ration your inhalers, what happens is your brain doesn't function really well, you run out of energy, you just don't have the good quality of life. You may stay alive, but don't ask anyone to try to run across the street, even for something small. These medications are just fundamental to human life. Thank you.
Thank you, Representative Cleburne. Representative Howard, final comments?
Madam
I apologize, Representative Driscoll.
Yes, I was wondering if the bill author on the DE1 amendment could also explain lines 1.12 through 1.16. I've kind of read through that, and as it references the previous paragraph that I had talked about with the medical supplies, just wanting to know how this integrates with the federal code, Title 26 and 42.
Representative Howard.
I may ask Mr. Chund to come help me with this. I would say, related to the deductible issue, we do know that Minnesotans, if you're on a high deductible plan, folks really hit the crunch earlier in the year, and that's partly why we want to make sure that this applies before the deductible. I'm just trying to remember if this is where we got at that, or if there was another interaction here that House Research can help me with.
Thank you. Mr. Chen.
So, Madam Chair, Randy Chen again with House Research. So what this is reacting, or what this language is, it's addressing some federal rules related to health savings accounts and catastrophic health plans. These are both high deductible health plans. And the federal rules basically say that, you need to count all of your costs toward the deductible. So what this is saying is that, that until the deductible is met, these provisions of the bill won't go into effect. So it's to comply with the existing, I guess, federal framework for these high deductible plans.
Representative O'Driscoll, follow-up?
Yes, please, and I won't belabor this, because it does talk about health savings accounts and the ineligibility. I thought I was with you until you said those deductibles have to be met first before the provisions in here of the 25 and 50 would kick in. Could you expand on that a little bit? Because then it seems like it doesn't do at all what Representative Howard's looking to try to accomplish, which is to put a outside cap on those outside of other deductibles and outside of other provisions in health policies.
Thank you, Representative O'Driscoll. It looks like Assistant Commissioner Peter Brickwitty is able to step in.
Madam Chair, for the record, Peter Brickwitty, Assistant Commissioner at the Commerce Department. Representative O'Driscoll, this language is in the bill, and actually similar language has been in other bills moving through the chamber. This deals with an unfortunate confluence of the policy goal of this bill and some federal tax law. So high deductible plans that feature a health savings account are required by federal tax law to have cost sharing in certain cases. And so this language would allow for those health plan designs to continue to exist, but keep them at the minimum level required to have that federal tax treatment and also then comply with this policy aim of this bill.
Representative O'Driscoll.
Well, thank you, Madam Chair. Then Mr. Brickwitty, this really doesn't accomplish what Representative Howard wants, is out of the chute $25 a month and $50 a month caps.
Mr. Brickwitty.
Madam Chair, Representative O'Driscoll, I would not agree with that statement. I think it affords the same policy goal to the extent that it can due to the tax treatment requirements under federal law. So I think it is applying the same principle to a set of plans that have a certain set of features required by the federal code, the federal tax code, which we obviously can't affect here in Minnesota. But I would not agree with that statement that it does not achieve the same policy effect. I wouldn't want to speak for the author, though.
Representative O'Driscoll.
I think I have my questions answered.
Thank you. Any further discussion to the bill as amended, members? Representative Howard, I'll give you final comments.
Thank you, members, and to all the testifiers as well. I'm just struck by the discussion and just this notion that we could somehow trust the pharmaceutical companies or trust the insurance companies or trust PBMs to be in this space advocating on what's best for Minnesotans, when I think all of us have heard story after story from Minnesotans asking us. They have dealt with these powerful interests, and I think that outcome has been clear. They're asking us to take up their mantle and to lean in to create a system that's a little more fair, that balances the scales a little bit. And I believe that's what this bill does. And in so many ways, we're helping provide a peace of mind for Minnesotans to afford their lives. We're actually going to help create healthier Minnesotans, as Representative Liebling mentioned. It really is a win-win. And I just have to say, I don't want to go all the way back to the debate on Alex Law, and I appreciate Representative Doubt's work on the working group on it, but to the public service announcement piece of it, one of the reasons we needed to pass that bill is because the pharmacy or the prescription drug plans that were sort of offered by the manufacturers weren't very accessible. But if you do need to access insulin, you can go to mninsulin.org and access insulin here in Minnesota because of that bipartisan law that we passed. And now this bill is the next step, and I would urge members' support.
Thank you, Representative Howard. I will renew my motion that House File 348 as amended be recommended to be re-referred to the Health, Finance, and Policy Committee. All those in favor, please say aye. Aye. Any opposed, say nay.
No.
The motion prevails, and House File 348 as amended is recommended to be re-referred to the House Health, Finance, and Policy Committee.
Thank you.
Representative Howard.
Thanks, members.